I'm going to introduce you to Professor Eduardo Gonzalez-Hernandez, who is a shoulder surgeon based in Miami. And his first talk is going to be talking about anatomy of the proximal humerus and how this influences fracture classification, as well as the rationale for plate design. Eduardo, you have the floor.
Thank you so very much. It is a pleasure to be here, and I have to thank Ali and Ramon for putting this together and doing this excellent effort in OrthoHub. We do need this type of venues for teaching, for learning, for advancing, and I really appreciate this opportunity. Michael Gardner and Joe Abboud are incredible surgeons. It's a great honor to be here. So here is my presentation, and I'm going to have a good time with this because I'll be sharing a lot of concepts which you probably don't see in the typical American Academy or our venues. This is an opportunity to talk freely, and it's great. Really, thinking outside the box is what needs to happen if we're going to make progress in this very difficult subject. So these are my disclosures. And I'll be talking a little bit about this concept of cross-screw fixation. And I hope to convince you that the effort needs to be made to better our devices, to better our understanding of these fractures, if we in fact are going to improve on our outcomes. And of course, there will be objections. I welcome the objections. We're going to have a good time today. So we need to start with a revisionary approach to fracture the proximal humerus. We need a better understanding about these fractures. We need to have a better understanding why locking plates actually fail so much. We need to have also more reliable implant design, and this will follow logically. Possibly, certainly expand our indications for internal fixation. We must not rely so heavily on the reverse shoulder replacement. For more success in our efforts, a systematic fracture reduction and fixation has to be done. And this is, Michael is going to talk to you about in detail, and I'm really looking forward to that portion. He will present some challenging cases. But we need to depart from positioning the plate to the shaft. We need to reference our plate positioning to the center of the humeral head. That's departure from convention, and that's important. And then also including our methodology of X-ray techniques intraoperatively, that has to be improved as well. So I start by this diagram because it defines what our box is. Basically, our current understanding has a lot to do with our common language, referencing back to this 4-part diagram. But look, this is 1934. And this is 2004. It's the same concept. It's revisited, but it is the same concept. And most of us really know it as the near classification. But there are problems with it, very serious problems with it that have kind of misled us, have misled our understanding for so many years. This is a better diagram, and I will explain to you in detail why I think we need to change a little bit of the key diagram to this fracture classification. Number one, the lesser tuberosity is a bigger fracture fragment than portrayed in any other classification. The lesser tuberosity has the biceps tuberosity with it, and it has blood supply. And it is so important to consider it as a very key component in our fracture fixation. Must not be left unrepaired, or even suturing it is not sufficient. The greater tuberosity fracture fragment is usually a comminuted shell, one that typically or frequently will lose its fixation if you use screws. It must be repaired with sutures as a rotator cuff is repaired. And more importantly, in our fractures classifications, the calcar is not included, not mentioned. And it turns out that the medial calcar really is the key to these fractures. So we must revise how we think about this. and how we draw these things. It's important. Now, when I think about fractures of the humerus, I think about the mechanism as well. For instance, you can have a mechanism which is an impaction type of a mechanism that leads you to this type of a pattern. And this one is a four-part valgus impacted fracture. Now, we know from this article in 1991 by the folks in Bern that about 70% or the majority of these actually are reducible and do well even before locking plates were available. So this type of fracture, when we see it, should not be addressed with a reverse replacement. Um, it's easy to reduce them, disimpact it, fill the void with bone graft, put your plate, suture your tuberosities, and be done. Expect a good outcome. Now, these other type of fractures, these valgus displacement, the mechanism of injury is a shear mechanism, a lot more damaging to the surrounding tissue, and leads to the failure of the calcar. So this is a very different injury. Okay, so I would propose that we look at this with an additional uh, uh, a five-part fracture element. The five-part fracture is very different than a four-part fracture. So if we think about it in terms of the number of fracture components plus the mechanism, then we are going to be more capable in deciding which ones should be replaced and which ones should be fixed. So a four-part valgus impacted fracture is one that will do very well with the fixation. And a five-part fracture, including the calcar, lesser tuberosity and greater tuberosity, the head and the shaft, we're going to have a hard time fixing it uh, with conventional locking plates. And perhaps we should think about replacing them. Now, it is true that there will be patterns that we won't be able to recognize or fit into one of these two. But in general, it gives you an idea that there is a better way of understanding these fractures. Now, I'll make reference about this particular pattern of fracture. Uh, the 4.5 fracture, you see this uh, extension of the calcar into the humeral head. This type of fracture has a better prognosis because, as Hertel pointed out, you have better blood supply to it. And Brooks, 10 years before, also made that observation. I call that the Brooks-Hertel pattern fracture that is probably amenable to fixation. All right. So it's a classification that points out real fracture patterns. We may improve in our fixation of those. Now, let's look at why conventional plating fails. Well, our current box of understanding is this. We position a lateral plate and we expect that to hold the head in place. Now, you only have a 1 or 2 centimeters of cancellous bone allowing you the fixation. That's tenuous fixation. And of course, with micromotion, as the patient starts to rehabilitate and so on and so forth, there's no opportunity for healing, and there's erosion and the penetration, avascular necrosis, and all these problems. We know that articular penetration is very common, sometimes more than 40%. Fracture collapse is worse when virus displacement. And avascular necrosis is a problem. These fractures do not have the opportunity to heal because of the micromotion, and there's no way that they can revascularize. So that is a real problem. But look, we had such good success with plate fixation in the distal radius. Well, the reason why is because the locking screws were really oriented ideally to counter the joint reaction forces. These screws are oriented tangentially to the joint. However, in the proximal humerus, the screws are oriented at right angles to the articular surface. And therefore, you are going to have erosion and joint penetration. It is simply not the same animal. It's a very different animal. And what happens if you suture the lesser tuberosity? What happens? The lesser tuberosity does not participate in supporting the humeral head, and then you get this basically um, uh, the lesser tuberosities never does heal to the humeral head. So that's a problem. That's why we came up with this concept of a cross screw fixation to minimize micromotion, to augment soft bone fixation, and to support the humeral head with the lateral plate. So that was our notion, and we've been working on it for a while. And this is how you accomplish it. You do the plate fixation initially, and then if you need to use cross fixation, if you need it, then you have that available to you. You attach the cross screw guide, and through the guide, then you assemble the cross screws to the main screws in the plate. And so what you're able to accomplish is a veritable scaffold underneath the humeral head. And that can really counter the reaction forces and be an effective tool. And this is how we do it. You have the plate, you assemble the guide to the screw. The guide is assembled to the screw, not to the plate, and that's why it's so tremendously accurate. So this is the guide. We drilled through the guide, and just to show you, the accuracy is right on point every time. There may be a situation where you need to adjust the orientation of your cross screws, and it's very easily done. You just adjust the guide and shoot again. Um, the design of these multiple screws was done so that you could support the head, or in fact, you could fix the lesser tuberosity. And I will talk about that later. So the question is, does the addition of cross elements really help in prevent subsidence? Does it really work? And Ali, this is a study from your colleagues at Bart's, Damasio, Olivia Damasio, and his colleagues who have come up with this wonderful study. 15 patients, very well matched between the conventional plates and this cross screw fixation. What they were looking at, the subsidence, and it's by looking at the ratio between the length of the screw and the distance from the plate to the head, you can pre-op, excuse me, immediately post-op to the last follow-up, you can actually see if there was any subsidence or any complications. So these are the results. 15, 15 patients in each group. Um, in Philos, you have near 50% of subsidence. In Pantera, none. In varus collapse, you have one in Philos, in Pantera, none. Screw penetration, 30% in the Philos. And in terms of avascular necrosis, you have 3 patients in the Philos group with avascular necrosis, none in the Pantera group. So there is a clear evidence that the concept works. Now, we looked at it in a mechanical study, cross screw fixation in soft bone versus a conventional locking screw from Synthes, and this is what we found. A synthesis screw at the bottom of the curve, this is what it does to soft bone. This is the fixation you get compared to any other. The top line is our screw with 2 cross screw fixation. The performance is not 10% or 20% better. No, it's 500% better. The difference is remarkable. It's absolutely remarkable. The synthesis screw loses its fixation already within half of a millimeter of displacement. And within a millimeter of displacement, you're down to 50% of its fixation and losing more. So no wonder we have such poor fixation with these plates. Um, Now, more importantly, if you look at the area under the curve for each of these graphs, that is the work necessary for screw removal. So if you look at this, what is the work necessary for removing the screw? 3 millimeters. For a synthesis screw is way down here, and for a screw with a cross screws is way up here. It's actually 30 times more work. So it's actually remarkable. All right. This is an article from our folks in Italy. 83 patients, 2-year follow-up, minimal IRB approval. It's a retrospective study, but the complication rate was only 9% compared to 40% that you typically see on the literature. only one screw penetration in a patient with where no cross screws were used. This article, this series was basically the use of cross screws was discretionary. So not all patients got cross screws, and the surgeon could decide who would get them or not. But in any case, only one case of screw penetration. It's remarkable. Three cases of avascular necrosis is also very low for this number of patients. So um, it is possible, and there is substantial evidence of this cross screw fixation. Now, with this particular device, you can use the plate as a conventional mode, or you can have the option of cross screw fixation. And so for the more unstable, more difficult patterns, you can actually resort to that particular feature. Now, um, a systematic approach, this is a slide that I'm going to skip because Michael it really is going to talk about the details of the fixation. But I do want to point out that we must, once you do the preliminary you do your reduction in preliminary fixation, you have to reference the plate to the center of the humeral head and not to the greater tuberosity. And that's how you will succeed and get better reductions and less malpositioning of your plate. So that's important to get the perfect result. This is what you want to achieve. Uh, Now, very important, the Calcar screw has to fit in the lower portion of the humeral hemisphere to really be of substance. And then intraoperative imaging, well, usually I bring the C-arm from the opposite side of the bed, and this is easy to get an AP view. And this is an axillary view, a slight extension of the shoulder and rotating the C-arm in the opposite direction to get the perfect views. And it has to be easy. It has to be this easy. This is an AP view, and this is your axillary view. And you should be able to go back and forth without it being cumbersome because the fracture itself is a challenge. You X-ray imaging should not be a challenge. So very importantly, we must suture at will, and we have a lot of amplitude to be able to suture the cuff, the osteo, the comminuted cuff. It's usually not possible to repair it with screws, so you have to have amplitude for repairing with suture. Now, here's the lesser tuberosity fixation. Lesser tuberosity is a large fragment. It has the biceps groove, and it is an important piece of bone with good blood supply. We must do better in terms of internal fixation. And we designed this guide not only to provide good support to the humeral head, but to provide an opportunity for fixation of the lesser tuberosity. This is how it appears on an axial view, and that important fracture fragment can be fixed and can be part of the rigid, stable fixation of our construct to really counter the displacement that you're going to see. And notice here, for instance, that what happens frequently when you get a vascular necrosis and you're using a standard locking plate is that the lesser tuberosity is alive and there is a line of non-union between the lesser tuberosity and the humeral head. And that is because we don't have an effective way of repairing the lesser tuberosity. Sutures do not do the trick. So rigid fixation of the lesser tuberosity provides a better mechanical stability to the humeral head and an opportunity to revascularize the humeral head. Um, in addition, if you have a rigid fixation there's less pain postoperatively and you can recover internal fixation better. Cross screw fixation, if you need to, is an option that I believe you should have, especially if you're a surgeon who fancies working on the proximal humerus. And the way to apply them is very easy. You slide extension and external rotation. The application of the guide no longer abuts the coracoid, and it's easy in this position to implant your cross screws. Um, it's a very low profile manner of fixing the lesser tuberosity without violating the blood supply that travels along the biceps groove. So preservation of the blood supply, it's important. I have this case, I'll talk to you that I like to share with you. 67-year-old gentleman with this fracture. And when you look at it, the head is completely uh, dislocated, but within the fracture site itself, you have a greater tuberosity, lesser tuberosity, shaft in the head, with a head that is completely looking 180 degrees in the opposite direction. 67-year-old, we proposed to him a fixation. He understood the concept, and this was 3 months after the surgery. This is 10 years after the fixation, with complete revascularization of the humeral head. He never displayed evidence of avascular necrosis, but for 10 years, he's been able to work as a mechanic and doing heavy work. And in our older population, we see absolutely no subsidence through here. So it's remarkable. Even in 97 years of age, who has this big calcar defect, very stable fixation. So we are excited about the option that you might have for cross screw fixation. And that's basically what I'd like to share with you. Thank you.
The risk of AVN, really. I mean, the risk of AVN often comes up all the time in our daily chat in the trauma room, right? So it's a 4-part fracture, therefore the risk of AVN is high. But we know that the reality can be slightly different, right? I mean, there are patients that I've seen who are 20-year-olds who have, fracture dislocations from trauma and have literally sheared off their head. And when I managed to achieve stable fixation of them, the head doesn't go into AVN. Now, I just want to have that one question for, maybe all of you can have a couple of minutes on it to say, what is your position on the risk of AVN, and when do you decide that is too unacceptable that you want to do an arthroplasty?
I'll go ahead, Eduardo.
Michael.
All right. Yeah, I'll take it first. So I have probably a position that's a little bit pretty far on one side of the spectrum. So I concur with your observations. We know that, and there was a question in the chat too. I think a very stable fracture essentially eliminates the risk of AVN. We know that when AVN occurs in without a malunion, with a well-reduced and healed fracture, it's well tolerated. So I don't personally change my treatment approach based on the risk of AVN. There are certainly reasons for arthroplasties, et cetera, but my own take on just kind of what I've seen and read and et cetera, I don't stratify based on AVN risk.
So you would fix most fractures in your hands?
Yes.
Perfect. I think we're on the same page here. So that puts a little bias to everybody else. But Joe, what's your view on it?
Yeah, I would agree. I mean, if it's fixable and the quality of the bone is good and the rotator cuff is good and the articular cartilage was healthy, and I'm going to get a solid fixation that's immediately stable, and I can start range of motion relatively quickly, I'm going to fix that. I think that the rate of AVN, even if, and I think when I was training, it was oversold to us as very high. I don't think it's quite as high as it was sold to us. But even when they do develop AVN, if they have stable fixation, and they may not be very symptomatic as it's not a true weight-bearing joint. And then if they do become symptomatic, they can have more anatomic options like anatomic arthroplasty or other options. So I do think that, when necessary to fix, and I think that's still yet to be totally defined at times, when necessary to fix, if it's fixable, then yes, by all means, we should fix it.
Perfect. Eduardo, your position is from your talk is the same as well. Stable fixation is a way forward, even for difficult fractures when we can achieve it. And if you do that, we all think that the risk of AVN with stable fixation is actually pretty low. And if it does happen, then the secondary outcomes for arthroplasty and other options remain there, and they're much easier options. So a second operation isn't a bad thing if AVN does happen in some small number of cases.
Well, yeah, I agree with all of you. I think that if we can save the humeral head, but I will tell you, I will go into some hospitals because I work in several different hospitals, And for instance, I will be limited to using a striker plate or a Synthes plate or a standard locking plate of whichever variety. I have opted not to fix a fracture and go into a reverse because the fixation is not stable enough with a locking plate. So I just know it's not going to work. But if I had the option for screw fixation, I might be more courageous and fix it. So, you know, it's just my hand is being forced by the limitations of the system. And I'm talking about the medical system, which you know, forces you to use implant designs that have more limited options.
Luckily, in the NHS, we don't have that problem. We can use what we want. Perfect. Mike, you're next. Thank you.